It really is a great pleasure to have Dr. Ayman and Dr. Osama today talking to us on a very interesting topic, really. And it is my pleasure to be introducing our two speakers. My name is Layla Abdelwaris. I serve as the Chief Scientific Officer and the Deputy CEO for the National Reference Laboratory. And I'd like to introduce you to our speakers today. Dr. Ayman El-Hattab is a consultant clinical geneticist in metabolic disorders at Mediclinic City Hospital, King's College, and Canaan Hospital, as well as the University Hospital Sharjah. He has the American Board of Clinical Genetics, the American Board of Biochemical Genetics and Metabolics, and the American Board of Pediatrics as well. He's also Associate Professor at the College of Medicine, University of Sharjah. He authored over 100 publications in various scientific journals and conducted several clinical research projects. Really is an honor to have Dr. Ayman with us. He has been classified, ladies and gentlemen, as one of the top 2% research scientists in the world by the University of Stanford. And this was actually published in the report in last October 2020, and that was in the field of biochemical genetics disorder. A true scholar in his field, which is a very rare field, and it really is very rare to find people such as Dr. Ayman, who is very, very well versed in their field, and there is a huge demand for such services here in the United Arab Emirates. Also, my pleasure to introduce my dear colleague and friend and scholar as well, Dr. Osama Aldirbashi. He's the head of our.
He's also supposed to join this meeting, but I believe he's not here.
Oh, sorry. Yeah, he's the head of the newborn screening and biochemical genetics at the National Reference Lab. Dr. Osama is certified as a clinical biochemical geneticist by the American Board of Medical Genetics and the Canadian College of Medical Geneticists. His expertise span newborn screening, inborn errors of metabolism, mass spectrometry, and metabolic biomarker discovery. Dr. Aldirbashi is appointed as Professor of Pediatrics at the University of Ottawa. His translational research focused on newborn screening and inborn error of metabolism. He received numerous grants, published more than 70 articles in prestigious journals, including pediatrics, genetic medicine, clinical chemistry, and you name it. He is a great, advocate, I would say, of biochemical genetic disorders, and a great supporter to the pediatricians and the physicians practicing in the field, from the laboratory point of view, the scientific point of view, and also help with the consultative services as well. And I'm not going to take any more of your time, so it is a pleasure to introduce our two eminent speakers, and they are going to talk to us about could it be metabolic presentation and diagnosis of inborn error of metabolism. Dr. Ayman, Dr. Osama, the floor is yours. Thank you very much.
So thank you very, very much, Layla, for the kind invitation and for the kind words and a nice introduction. It's actually my honor to be here today and talk about this very interesting topic with my dear colleague, Dr. Osama. So yes, we'll be talking about presentation, diagnosis, and some aspects of treatment about common inborn errors of metabolism. So the objectives, yes, is to describe the common ones, urea cycle disorders, organic acidurias, and fatty acid oxidation defects. First, we'll just give brief introduction about metabolic diseases, or we can call them inborn errors of metabolism. These conditions, one by one, they are individually rare, but when you put them together, they are relatively common. Now, age of presentation varies from prenatal life till late adulthood, so they can present at any age. Sometimes they have non-specific presentations and non-specific manifestations, this is why diagnosis is sometimes very, very challenging. They can be very severe and even fatal at the same time. Many of them can be treated. This is why it's very important to make an early diagnosis to prevent mortality and morbidity. And most of these conditions are autosomal recessive disorders, so they are very common in our region, like all other recessive conditions here. So if you want to give a simple definition for metabolic disorders, we have an enzyme that converts a substrate A to the product B, and if we have deficiency in this enzyme, we have excess of A, which can be toxic, and deficiency of B, which can be essential. So this is like simply the concept of metabolic diseases. These are like genetically conditions due to defect in an enzyme or transporter in the pathway, catabolic or anabolic pathway, and this will lead to a blockage of this pathway. Now, we will discuss metabolic diseases through case presentation. We'll present like 3 cases, and I will start with the first one. So this was a 3-day-old baby boy brought to the emergency department with lethargy and poor feeding just the day of presentation. Now, the prenatal history was normal, nothing significant. The baby was discharged home the day before on the 2nd day of life. However, since just in the 3rd day of life, it starts to have poor feeding and decreased activity. Now, parents are non-consanguineous, but we have a history of the mother's sister had a boy who died at 7 days with diagnosis of sepsis, but they were not sure about this diagnosis. Now, when the baby was examined, he was afebrile, but clearly he was lethargic and he was tachypnic. In addition, the temperature was low. And in the neuro exam, activity was low and the baby was hypotonic. Now, of course, in this picture, we should suspect sepsis, definitely. So septic workup is the first thing to think. But in addition to that, we need to do the basic biochemistry investigation, which include blood gas, electrolyte, liver function, and of course, glucose, ammonia, and lactate. In addition to urine analysis, including the ketones. Now, if we do this basic biochemistry investigation, we will know if the child has hypoglycemia, hyperammonemia, or metabolic acidosis, and this will help us very much in suspecting metabolic disorders. So for this particular case, we had alkalosis, right, with low CO2. So this is respiratory alkalosis, and ammonia was very high, close to 600. Now, when we have this picture, this is like the classic presentation of a classic urea cycle disorders. We have respiratory alkalosis and very high ammonia. The next step is to do 2 important tests, plasma amino acids and urine organic acids. And from these tests, we concluded, the results of these tests were suggestive of OTC, ornithine transcarbamylase deficiency. So, of course, Dr. Osama will talk about these tests and the diagnostic approach, and I will come back later to this case to discuss briefly the management. Let's move to the next case. Again, neonate. This time 5 days old female presented to the ER with kind of similar presentation, poor feeding, decreased activity, tachypnea. Again, nothing in the history in the pregnancy or delivery, but this time parents are cousins, and they have, this is their second child. When the child was examined, the baby was pale, again tachypnic, and lethargic with decreased activity and hypotonia. The same thing, we will do septic workup, but in addition to septic workup, definitely we need to do the basic chemistry test. And this time, we had severe metabolic acidosis with low bicarb. Lactate was mildly elevated. And interestingly, we have pancytopenia, low hemoglobin, low white blood cells, and low platelet. In addition, ammonia was mildly elevated, 230. Something also significant in typically neonates, they cannot make ketones. So having positive ketones in neonates is very significant and alarming for metabolic conditions. Now, with this presentation where we have like a metabolic acidosis, elevated ammonia and ketones, definitely we need to suspect organic acidemias. And if we suspect organic acidemias, we need to do also two tests: urine organic acids and acylcarnitine profile. In this particular case, we have like something significant. The nurse noticed that the baby has unusual udder. It likes sweetie feet udder. And this is like more consistent with one specific type of organic acidemia, which is isovaleric acidemia. And indeed, the organic acids and acylcarnitine profile results, as Dr. Osama will show us, were consistent with isovaleric acidemia. Again, I'll come back to this case after Dr. Osama discusses the laboratory and diagnostic approach, and I will talk a little about the management. The third and last case was a 16-month-old girl. Now, she's been healthy, but now she presented to the emergency room because of tiredness and weakness. 2 days before presentation, she had signs of cold, like runny nose and decreased appetite. And in this morning, the morning of presentation, when the mother tried to wake her up, she was very tired and doesn't want to leave the bed. She had some fever, runny nose, mild cough. Her history, past medical history, was completely negative, and she has normal development. She eats regular food, but over the past 2 days, because of the illness, she's not been eating well. And last time she ate was like 6 p.m. So she was fasting, like she didn't eat anything since last evening. And her parents were cousins, and again, this was the second child. Now, and the examination showed tachypnea, tachycardia, and she had mild fever. She was lethargic. And something significant noticed here, mild hepatomegaly. The liver was about 2 centimeters below the costal margin, so the liver is enlarged. And in your exam revealed weak, lethargic girl. So same thing, we did the, of course, you need to suspect sepsis, but also the basic workup revealed two significant things: the hypoglycemia, significant low blood sugar, and negative ketones. So here we have hypoglycemia with no ketones. Again, when we have like hypoglycemia with no ketones, or what we call is hypoketotic hypoglycemia, we should suspect fatty acid oxidation defects. And if we suspect this group of diseases, the test to do is acylcarnitine profile, and results in this case were suggestive of MCAD, medium chain acyl-CoA dehydrogenase deficiency, and the clinical representation is also very typical for these cases. Again, I'll come back to this case to talk a little about the diagnosis, the management. So at this point, I will leave the floor to Dr. Osama to talk about these different testing modalities and the diagnostic approach for these cases. And I'll come back later and like take just a few minutes to talk about the management.
Thank you, Dr. Ayman. Can you hear me?
Yes.
Perfect. Good afternoon, everyone. Thank you very much to Dr. Ahmed and Dr. Layla for the arranging this presentation at a very short notice, and I really appreciate the introduction of Dr. Layla. I also want to thank Dr. Ayman for his comprehensive introduction that made my work easy. So can you see my slide?
Yes.
Yes.
Perfect. So in the coming few slides or few minutes, I'll be talking about the basic diagnostic workup when we suspect an inborn error of metabolism. And here I refer to three main tests: the amino acid analysis, the organic acid profiling, and the acyl carnitine. Now, if we do these three basic tests, we can get a wealth of information, and I will start on the amino acids. Okay, so going back to the first case of Dr. Ayman, that was diagnosed with OTC deficiency. So the most significant finding was ammonia. So in a 3-day-old baby boy. So where does this ammonia come from? So ammonia actually is a product or a byproduct that comes from the degradation or the metabolism of amino acids. And here I'm depicting amino acid, and ammonia is shown in red. So these amino acids usually come to us from either diet or from the body protein metabolism. And we, as our bodies, cannot store amino acids, excess amino acids, like it does in case of fat, etc., then these amino acids, if not utilized, have to be metabolized, and the ammonia is produced. Now, ammonia is very toxic to the brain, and it has to really be quickly removed from the body. So in case of like hyperammonemia is truly a medical emergency, and it could leave a significant damage to the child's brain if persists for some time. So the body deals with ammonia through the urea cycle. So I'm showing here the urea cycle, and I hope this is not so much for this presentation. So the first part of the cycle, which is the mitochondrial part, have the three first steps until the synthesis of citrulline. Citrulline is transported outside the mitochondria to the cytoplasm, and then the urea cycle keeps going. So in the urea cycle, this ammonia is incorporated with or condenses with the bicarb and ATP to form carbamyl phosphate, and this is the way that we get rid of ammonia. Now, there is a number of enzymes that are involved in the urea cycle, and these are listed here. There are also two important transporters that also transport urea cycle metabolites in and out the mitochondria or the cytoplasm. So there is a defect in this cycle in the child that Dr. Ayman presented. However, just to give you some classification of hyperammonemia, it could be either metabolic or non-metabolic, like in case of liver disease or infectious disease, or even the transient hyperammonemia. Hyperammonemia also can be caused by a secondary to another defect, not necessarily in urea cycle disease. However, our case today is mainly related to urea cycle, which is the primary type of hyperammonemia. So this is hyperammonemia, and when we analyze amino acids to detect hyperammonemia or to differentiate hyperammonemia, the most important analyte to look at is the citrulline. So as they say, the money is really in the citrulline. So you have about 30 amino acids analyzed in one run, then you look first at citrulline. If citrulline is low, that is one path. If citrulline is high, that's another path. So in our case, citrulline is expected to be low, and this patient also is expected to show other metabolites such as orotic acid, and that's why we found that this patient had OTC. Now, the way that we measure plasma amino acids, we do this using amino acid analyzers, such as the cation exchange or the mass spectrometric analyzers, and both of them rely on the theory of chromatography, where mixtures are separated during the retention or as they pass through the column, and then the signal is recorded, and each peak here represents an amino acid, and the height of the peak or the area of the peak represents the concentration of amino acid. Next slide, I'll show you a true amino acid chromatogram by amino acid analyzer. As you see, about 30 analytes are separated, and in this case, citrulline is somewhere here. So this is citrulline. For example, arginine is here, serine is here. So different amino acids elute at different time, and one run takes about 2 hours on the system. Now, this peak height represents the height or the concentration of the amino acid in the sample. Now, going back to the case of Dr. Ayman, as I said, this is the urea cycle, and in the case of Dr. Ayman's patient, citrulline was truly low. It was almost absent. So we knew that because citrulline is very low, so citrulline synthesis is not working. So it's one of these enzymes, CPS, OTC, or NAGs, because ammonia, and that's why ammonia is accumulating, because this step is not working. So when we analyzed organic acid to detect orotic acid, which is a product of carbamyl phosphate accumulation, we found that orotic acid is high, and when orotic acid is high, this is a combination of low citrulline, high orotic acid on organic acid analysis tells us that this is an OTC. Now, this way we have solved this case, and then we reach the diagnosis. The next slide, I'll show you some other examples on how to use amino acid for the diagnosis of different disorders. So urea cycle diseases, we can detect CPS, OTC, citrullinemia, arginosuccinic aciduria, argininemia, HHH syndrome, and NAGS deficiency. And each one of them has its own marker and additional marker, and the preferred sample for these is in blood. All these disorders are genetic. They are inherited as autosomal recessive, except OTC, which is autosomal, which is X-linked recessive disorder. The next group of disorders, the aromatic amino acid disorders that can be detected by amino acid analyzers, PKU, and the PKU variants as the biopterin cofactor synthetic disorders or regeneration disorders, tyrosinemias, type 1, type 2, type 3, all of them can be detected by amino acid analyzers. As well, branch chain amino acids, MSUD, can also be detected by maple syrup urine disease, of course, here, can be detected by analyzing branch chain amino acids. And here, the ratio of the different branch chain amino acids, like in valine, isoleucine, and leucine, tells us that this is most likely a defect in branch chain amino acids. Non-ketotic hyperglycemia, as well as homocystinuria, sulfite oxidase deficiency, molybdenum cofactor, and the list really goes. So it's one test that tells us a lot about the disorders that we look at in amino acid metabolism. So this is the importance of this test, that it tells you about the status of a large number of genetic disorders. Now, we have to be careful of medication. So if the patient is on medication, this might interfere with amino acid analysis. Also, when the sample was collected, was it postprandial, fasting, etc., because feeding status affects also the results of amino acid analysis. And it's very important also that the sample is transported to a lab that is does not take long transit time, like sending to another country, where you have sample degradation and then you have unusual picture in your samples. So this is the part that I wanted to talk about amino acids, and next I'll shift gears to the next important test, which is organic acid analysis. We do organic acid analysis in urine mainly because organic acids are polar compounds, and we do the analysis by GCMS. So this is a GCMS. This is a true picture of a GCMS where we have the autosampler and then the main instrument with the column here and then the mass detector, and the signals are analyzed on this computer. The diagram of the GCMS, so it's gas chromatography. So we have a carrier gas that would carry the sample that's injected here into a column, which is in an oven that's programmed, and then the separation will happen similar to what we saw in amino acid analysis according to the retention time, and then we get the results displayed on computer. Okay, so these compounds, organic acids, are very small compounds that are polar and carry a carboxylic group, and they mainly derive from amino acids. So organic acids, the origin of organic acids is amino acids after the deamination step. So most of organic aciduras are actually errors in the degradation of amino acids. However, the amino acid precursor does not accumulate in organic acids because the amino acid metabolism has already, processed well, so that the affected amino acid does not accumulate, but it's the organic acid that accumulates. And the best matrix to do this analysis is actually urine, and urine has to be better collected during a metabolic crisis so that we know what is going on. We extract organic acids from urine, we derivatize them, and we analyze them through separation and then detection by mass spectrometry, and then the interpretation is really qualitative. We look at the pattern. There is no much value for quantitative analysis in urine organic acids. Okay, so this is one chromatogram from a normal urine organic acid. So as you can see, we see lactic, oxalic, pyruvic, hydroxypropionic, phosphoric, succinic, fumaric, other Krebs cycle metabolites such as citric to oxoglutaric, etc., etc. And one run takes about 30 minutes. Each peak, of course, represents one organic acid, and the best sample for this analysis is the random urine. Now, urine organic acid really provides, it's one of the most complex tests that we do in biochemical genetics, but it really provides a wealth of information that, if used correctly, you can solve very difficult metabolic cases. Okay, so remember with me that it's about 30 minutes run, and you see this kind of profile with those kind of normal or naturally found in urine analytes. Now, if we go to the patient of Dr. Ayman, the patient with isovaleric acidemia, where Dr. Ayman highlighted the sweaty foot odor, this actually comes from the accumulation of organic acids. Now, the patient had metabolic acidosis with elevated ketones and ammonia. Okay, so basically this is the algorithm that we follow. So it's a patient with metabolic acidosis, with ketones, with high ammonia. Then we either end up with a mitochondrial disorder or an organic acidemia, depending on lactate being high or low, and in our patient it was an organic acidemia. Now, if there was no ketosis, then the story is completely different. If it was metabolic acidosis with normal ammonia, again the story is different. However, in our case it was an organic acidemia suspected, and that's why we did the organic acid profile. So again, in this 3-all-day baby girl, okay, this was the organic acid profile. As you can see, there's a prominent peak that was identified as isovaleric glycine. And this is the way that how our body handles excess isovaleric CoA. So it conjugates us with glycine and gets excreted. However, because of the metabolic block in this step, then isovaleric CoA, it truly accumulates in our bodies, and then this accumulation causes the picture that we just saw in the urine here. So again, isovaleric CoA dehydrogenase deficiency is an enzyme that is required for the degradation of branched chain amino acid leucine, which is first deaminated to ketoisopropionic acid and then continues to be processed or metabolized to produce finally acetyl CoA and acetoacetate. So it's the precursor of this acid is actually an amino acid, and this pathway, the branched chain amino acid valine isoleucine leucine pathway, has about 10 or a little bit more of disorders, including propionic acidemia, methylmalonic acidemia, isobutyryl dehydrogenase deficiency, methylbutyryl dehydrogenase deficiency, HMG, etc., etc. So in our case, the defect was here, and this technique can also detect all other amino acid, organic acid disorders, and this is the list that I could put together, but I know that there are many other organic acid disorders that can be detected by GCMS analysis. So in some cases, GCMS is helpful, but not necessarily diagnostic, and these are actually the amino acid disorders. And the third case Dr. Ayman mentioned of MCAT, where we can see phenolic glycine, but it's better to do acyl carnitine for those patients. Now, these are the classical organic acidurias that we know. However, there is also a number of recently described organic acid ureas, and this was published by the American College of Medical Genetics in 2018 as an update. The amino acylase, the aromatic amino acid decarboxylase deficiency, and one of them is the short branch chain acyl-CoA dehydrogenase, which was, according to this publication, recently described. However, we already see it in our region, and this is one case of SBCAD, or 2-methylbutyrylglycinuria, where we can see these two abnormal peaks in addition to the 2-ethyl-3-hydroxypropionic acid. So we have the new ones, we have the old ones, we have the classical ones. So it's always good to have this test available to us so that we can provide it to our patients to solve their cases. Now, the last thing that I want to talk about is the acyl carnitines. Now, acyl carnitines are intermediary metabolites in the fatty acid oxidation pathway. Okay, so we can measure them in dry blood spot as we do in newborn screening. They can also be measured in plasma, as well as in some conditions like glutaric aciduria, where urine can also be helpful. Now, acyl carnitines shown here. So this is the carnitine moiety, and this is the acylic group. So this acid can be C16, C18, C14, C5, etc., etc. Now, the MSMS is the best technique to do this because in a very short run, it can measure large number of analytes based on the mass to charge ratio, and in fatty acid oxidation as well as organic acidureas, those compounds actually accumulate. Now, in mass spectrometry, basically we are measuring the mass, and this is the true look of one of the older versions of mass spectrometers. So the second case of isovaleric acidemia, again, testing her for acyl carnitine profile. This is, quickly for those of you who are familiar with this is really an abnormal profile, seeing the peak at 302 accumulating to this level, and this indicates that C5 carnitine or isovaleric carnitine is very high, and actually the level is more than 9 with a cutoff of 0.8, giving rise to more than 10-fold accumulation. Okay, we don't only look at one analyte, we look at ratios. So in this case, look at C5 to C3 ratio, for example, which is usually 1 to 1 or even half to 1. It's here 53 folds in favor of C5, C5 to C2. C2 is usually high in normal babies as well, but here it's even less than C5. So this is a very good way to judge the profile based on the holistic picture of the profile, not necessarily a single. Now, let me move to the last patient of Dr. Ayman, the patient with medium chain acyl-CoA dehydrogenase, who presented with hypoptotic hypoglycemia, low ketones and low glucose. Now, if we start with the hypoglycemia with low ketones, so we are actually here. So hypoglycemia without ketones. So there's a defect in the ketone body generation. Now, this is most likely to be fatty acid oxidation defect if lactate was high. However, if lactate was normal, then other causes are in the picture. So in our patient, it was most likely this pathway. And when we looked at the acyl carnitine profile, we could see C0 free carnitine, C2, and then the medium chains C6, C8, and C10 shown here. And this accumulation of the peak at 344, which is C8, is very diagnostic for for MCAD, and the C8 is, of course, the octanoyl carnitine. So this is a defect in medium chain acyl-CoA, and this is the short chain region, C2, C4, long chain region, C16, C18, and we are talking about a defect in the beta oxidation on the short chain region. Now, what are the disorders that can be detected by acyl carnitine profile? You have a large number of fatty acid oxidation disorders, as well as a long list of organic acid disorders, carnitine uptake, carnitine palmitoyl transferase 1, CPT2, CAT, VLCAT, LCHAT, etc., etc. And on organic disorders, the famous propionic acidemia, methylmalonic acidemia, thermodynamic encephalopathy, etc., etc. So it's one test that can provide you with many diagnoses. This is my last slide. So I hope that I gave you a good introduction to the basic diagnostic workup on these three important tests where you analyze amino acids in the right matrix and get information about a large group of diseases in the amino acid metabolism, or you analyze organic acid by GCMS or do the acyl carnitine profiling. And I will hand back to my colleague, Dr. Ayman. So, Dr. Ayman?
Yes, I'm just now use 1 second. I'm just trying to share back. Okay, 1 second. Yes, this is okay. So now you see my slides again. Okay.
Yes.
Thank you very much, Dr. Osama. This is really comprehensive and very helpful explanation and discussion for what we use and what you have explained here makes it very clear that we won't be able to make diagnosis, we won't be able to help our patients if we are unable to do these tests. These tests are needed really to make a quick diagnosis and to initiate a treatment. And as you said, I mean, we need to have these tests done locally. When we send these tests abroad, this will take a long time. And by the time that we have results, they are not that useful. So absolutely having these tests locally is very essential. So we can send the sample, we get immediate answer and initiate immediate treatment. Like these diseases, I mean, it's like typical. If we don't diagnose many of these conditions in a timely manner, we will have high mortality. We will have like severe complications. So we'll briefly, like in like few minutes, I will talk just about principles of management. The first case with urea cycle disorder, in general, in all metabolic disorders, we have the acute management and then we have the long-term management. So for urea cycle disorders, if we start with the acute management, then the main two goals is to decrease the production of ammonia, and the second goal is to remove the ammonia. Now, as you clearly mentioned, that ammonia comes from protein, and this protein, either protein intake or our body protein breakdown. So to decrease the ammonia coming from our protein intake, then we need to restrict protein intake. This for 1 or 2 days. And this restriction should be limited only to 24 to 48 hours. After that, we need to introduce a small amount of protein through the essential amino acid formula. Now, to suppress the catabolism or the protein, that is the body breakdown of protein, we need to provide enough energy in the form of dextrose or intralipid, and also we use insulin as a powerful anabolic hormone. Continuous infusion of insulin also will help and reverse the catabolic state, and early introduction of essential amino acids also will help in reversing the catabolic state. Now, to remove the ammonia, now if we have very high ammonia, then the way to go is through hemodialysis. This is a way to remove ammonia quickly through hemodialysis. Now, but also we have a medical way of removing the ammonia, what we call them the ammonia scavenger drugs. Now we have glycine carries 1 nitrogen and glutamine carries 2 nitrogens, and these are like considered the currency of nitrogen in our system. So we can use a sodium benzoate to bind glycine to form hippurate, and this hippurate can be excreted in urine. In addition, we can use a phenyl acetate, which binds to a glutamine to form phenylacetyl-glutamine, which also can be excreted in urine. So we have this medicine combination of sodium benzoate and sodium phenyl acetate as IV formula that can be given to lower ammonia quickly. Also, we can use IV arginine in urea cycle disorders, except for arginase deficiency. Now, in addition to removing ammonia and decrease the production of ammonia, we need to be careful about trying to reduce the neurological complications by avoiding fluid overload, because these individuals are at higher risk of having brain edema, treating seizures, which also can have bad consequences. And of course, we need to treat precipitating factors if they are known, like giving antibiotics if we have infections. This is related to acute management. Now, for long-term management, diet is very essential. We need to restrict the total amount of protein intake, and in addition, we need to give part of this protein intake as essential amino acid supplements. Also, we use for ammonia scavengers, we talked about the IV formulary, but for long term, we use oral sodium benzoate and sodium phenylbutyrate, which is the precursor for phenyl acetate. And we can replace arginine and citrulline depending on the defect. We have one specific drug, carbamyl glutamate. This is used in particularly for an acetylglutamate synthase deficiency, because it's analog for an acetyl glutamate. So it's for this condition, it's very helpful. And sometimes we have severe cases and we need to do a liver transplant. For the second case, organic acidemia. In general, acute management is the same. We need to hold protein intake for 1 or 2 days. Suppression of catabolism via dextrose, intralipid, and insulin infusion. But here, because we have severe acidosis, we can use sodium bicarb to improve the acidosis, and also we can, for removal of the organic acids, we can use carnitine, high doses of IV carnitine, which binds to different organic acids to form compounds to be excreted in urines. And again, we can use hemodialysis if we have refractory acidosis. Long-term management depends on the type of organic acidemia. Here we have the 3 commonest types. The case that we presented, isovaleric acidemia, and isovaleric acid comes from leucine, so we need to use leucine-restricted diet, in addition to glycine, which binds to isovaleric acid to form isovaryl glycine, and this can be excreted in urine. Now, for propionic acidemia and methylmalonic acidemia, we have a special formula that doesn't have the amino acids that produce the propionic acid, isovaline, valine, methionine, and threonine. And we can use some vitamins, which are the cofactors for that deficient enzyme. We can try them, like biotin in propionic acidemia and vitamin B12 in methylmalonic acidemia. Finally, for fatty acid oxidation defects, we can, acute management is mainly treating the hypoglycemia, and the long-term management depends mainly on diet, fat restriction, and avoid fasting by giving frequent meals. Sometimes we use uncooked cornstarch, which requires longer time to digest, so provides the body with glucose for a few hours. Now, medium chain triglycerides are used for long chain fatty acid oxidation defects like VLCAD, but not for MCAD. MCAD, we don't give them that because they cannot break down the medium chain fats. Okay, so these are regarding management. Some indications to consider metabolic workup, like in these cases that we described when we were concerned about sepsis. So yes, when we have unexplained neurological manifestations like encephalopathy, hypotonia, lethargy, seizures, if we have family history of metabolic disease and we need to examine other siblings, when we have developmental delay or behavioral disorders or movement disorders, catastrophic illness in a newborn where we have like yes a baby like the first two cases where they just presented with lethargy and then hypotonia and decreased activity. Sometimes we have illnesses, increased responses with intercurrent illnesses or sometimes manifestations related to diet. Hepatomegaly or liver disease, cyclic vomiting or recurrent vomiting can be due to metabolic disease and failure to thrive, of course, and in some occasions metabolic disease can be associated with dysmorphic features. So I think we need to have low threshold of performing metabolic workup, and the commonest presentation in our clinics is intellectual disability or developmental delay. So this statement was published by American Academy of Pediatrics back in 2014, and clearly it says all children with intellectual disability and developmental delay, if you don't have a clear answer for this delay, they should have metabolic workup, and the main three tests are acylcarnitine profile, amino acids, and organic acids. So this is like essential for these children, and we have many children with delay and who need to be evaluated to rule out the possibility of metabolic diseases. Again, these diseases are treated. Many of these diseases can be treatable, and treating these conditions will prevent complication and improve outcome. So thank you very much, and Dr. Osama and I will be around. If you have any questions, we'll be happy to take them.
Thank you very much, Dr. Ayman and Dr. Osama, for this very elegant presentation and a very nice, comprehensive review of three very important disorders here. We'll open the floor for questions from the participants. Let's see. I'll read the comments if anybody. Okay. Somebody I think is asking if we can share the presentation. We can, I don't know how you guys, how you feel. Somebody's asking if we can share the presentation, I suppose later on.
Yes, I mean, I don't mind. If Sam agrees, I'm happy with that.
Thank you very much, Osama. I think we can. Any other question from the group? If you can please, there is a hand sign here at the upper right corner if you want to take on that and okay. No questions from. Oh, okay, there is a question from Faisal.
No, I don't have a question. Thank you.
I'm sorry, I think I saw that your hand is raised. So I have a question then, Dr. Osama, for you. So what is the effect of pre-analytical variables? By that I mean, fasting or fed status of the child on the diagnosis of these disorders. And do you prefer one sample or the other, or it doesn't matter, or the best would be during the acute metabolic crisis? You're muted, Dr. Osama.
Dr. Osama, you're muted.
Oh, I think, okay, he's coming to my office, I think. You are unable to.
No.
Oh, okay.
It's frozen.
Oh, okay. Do you want to give the answer?
Yeah.
Yeah.
We're gonna switch chairs just a second.
Thank you. Okay. So sorry, my computer was just got frozen, so I could not take the question or answer the question. So basically, the question is on pre-analytical factors. Yes, of course, pre-analytical factors are very important for amino acid analysis because we know that if the patient is or the sample is collected postprandial, then the effect of nutrition will be obvious in the sample. Now, for the acyl carnitines and fatty acid oxidation disorders, to detect a disorder, we prefer a fasting sample because then we really want the patient to go through the activation of their fatty acid oxidation cycle. And then if they are fasted and then they have an enzyme deficiency, the abnormality will be obvious. It is actually one of the difficulties that we face in the lab when we receive a sample from a very well-nourished baby, where the abnormalities will not appear in the fatty acid oxidation. Now, for urine organic acid, of course, a random urine is preferred. However, if possible, if at all possible, a sample collected in the morning or during the metabolic crisis would be best. Now, just to add on the pre-analytical factors, I think, unfortunately, it's the transit time between sample collection and the start of analysis is also important. So if the sample is left, for example, in the airport, where things like exposed to humidity or to weather conditions, then some of the important analytes, for example, methionine, will deteriorate as an amino acid. The short chain acyl carnitines, like C3, for example, might break, producing a false image of another disorder. So instead of having normal free carnitine, then free carnitine will look higher because of the degradation, and this might give you the impression that you are dealing with a CPT1 case, for example.
Thank you, Dr. Osama. And the question for Dr. Ayman, what would be the percentage of babies who would end up having metabolic disorders in the retardation, the mental retardation developmental delay?
So Dr. Ayman, can you hear me?
Yes. The question is about like the percentage of children that.
Dr. Ayman, you muted again.
Okay, so now, yes, yes. So yes, the question was about like a percentage of children with metabolic diseases among metabolic, yes, and like children with metabolic diseases, like if we look at babies with developmental delay, like what the percentage will find children with metabolic diseases. I don't have a specific number, but it's not uncommon, particularly in places where we do not have a newborn screening. Because here, in newborn screening will detect many of these disorders. But in places where we don't have a newborn screening, more percentage of these disorders will be detected later, unfortunately. But it's not uncommon. And then still, I think, not me, I mean, just American Academy of Pediatrics recommend performing these tests for all children with developmental delay if we don't have a clear answer for their delay.
Dr. Ayman, Dr. Osama, I have a question for you regarding in utero injury. Most of the urea cycle defects, from what I understand, occur after the feed in the postnatal period. Is there any injury during the in utero phase? I mean, obviously the bowel is sterile, so there isn't that much of a source of ammonia from the gut. But what about from the placental nutrients?
So, thank you, James, for the question. So the mother, in most of those conditions, the mother is a carrier. So the mother herself is not, of course, affected. And therefore, the ammonia metabolism in mother should be okay. So the placenta will not have high levels of ammonia. Now, to my knowledge, those disorders usually present after birth and not in utero. Now, in this case, the child is born and they look healthy, they feel healthy, and then after they start their own metabolism, then the ammonia starts to accumulate, and unfortunately, the downhill is really quite quick, because once ammonia is high enough to cross the blood-brain barrier and then accumulate in the brain, the signs of brain toxicity start, and then the child starts to have hiccups, apneas, etc., etc. And I'm sure Dr. Ayman has comments as well.
Yes, no, I completely agree. Yes, during pregnancy, the mother's body will take care of clearing all these abnormal metabolites. So yes, the baby is born completely healthy, and this is why we do newborn screen on the second day of life. Because if you immediately do a blood test for the baby, it's actually like the same as the mother. So we don't do a newborn screening early. During the first day, we wait for the second day when the baby starts doing his own metabolism. So yes, no, I mean these conditions will typically present. It depends on the severity, but the severe forms, yes, will present a few days after birth when baby start feeding and toxic metabolites start accumulating. But at birth, everything will be normal.